So these are my disclosures. The question in my mind is not whether we are measuring the right factors, but are we measuring all of the right factors? And I'll take you through this presentation where hopefully I'll try and persuade you that simply focusing on quality of life or mood is not sufficient to give us the full rounded picture for how we might help people to self-manage their psoriasis more effectively. So, of course, all of you will be very well aware that the current measurement strategy as promoted by NICE in the UK is to focus on disease progression, which you're all doing very effectively, looking for improvements in skin, either with a physician global assessment or PASI or another kind of measure that you'll be using in your individual situations. And also to measure quality of life impact, which I'm hoping that the majority of you will be doing. And of course, quality of life encompasses physical functioning, psychological functioning, and social functioning to some extent, although we know that there are some problems with quality of life measures. In addition to that, many of you will be very well aware by now of the comorbidities associated with psoriasis, psoriatic arthritis, for example, and cardiovascular disease risk factors, including being heavy, being very overweight, being obese, smoking, heavy alcohol intake, amongst others. Many of you are already measuring those features of psoriasis, but I also wanted to draw your attention to some of the other related factors. I've talked about alcohol consumption and mood to some extent. We know now that mood is a significant feature of living with psoriasis, low mood in particular, but also anxiety. But I also wanted to focus a little bit on non-adherence and how we can understand non-adherence, because it's a persistent feature of psoriasis management that many of you clinicians will be struggling with. Trying to understand why patients don't take their medication when, of course, you know that it will benefit their psoriasis. And in order to do that, I want to help you to understand some of the underlying thought processes, the cognitions that feed into that feature of behaviour. So we know that individuals, our individual psychology, all of our psychology is made up of what we think, cognitions, how we feel, mood, and of course that then leads to some behavioural factors which we can predict from mood and cognitions. But in particular, I wanted to focus on beliefs about illness and beliefs about medicines, because in this context, these are the key cognitions that we need to be focused on. So I wanted to draw your attention to the importance of illness beliefs. We know that in other long-term conditions, individual beliefs can predict outcomes from a range of long-term conditions, including diabetes functioning, diabetes management, cardiovascular disease, chronic fatigue syndrome, a whole range of other long-term conditions, stroke outcomes as well. And we know that in psoriasis, illness beliefs were found to be better predictors of outcomes than the severity of the condition itself. So simply the extent and involvement of skin in psoriasis is not enough to help us predict patient behaviour in relation to self-management and in particular adherence. And of course we've known that for some time now, and Professor Chris Griffiths, who I hope I'll see at the EADV, will be in the audience, he's done some of the groundbreaking work with psychologist colleagues in Manchester on the importance of understanding illness beliefs in psoriasis specifically. Chris has laid the groundwork for much of that. Patient beliefs are partly shaped by information, whether that comes from their healthcare providers or whether that comes from high quality sources, approved sources online, but also from less reliable sources, from the features in women's magazines or magazines, and television series when they feature on a character in a soap opera, for example, who has a particular condition. So those less reliable sources are also feeding into patient beliefs. But we know the clinicians are not exempt from some of these the illness beliefs. We know the clinician beliefs about psoriasis can also drive clinician behaviour, because we're all human. And our work more recently on this, and following on from the IMPACT programme from Manchester, where we identify the clinician beliefs about medicines, especially new medicines that are coming online, and how clinicians think and feel about those new medications, is communicated to patients, and it helps to influence the way that patients think and feel about those medicines, and leading to whether they do or they don't continue to use those medications. These are known as the placebo effects or the nocebo effects, the negative placebo effects, if you like. And so we need to start thinking about how these illness beliefs can not only be shaped, but can be changed within a clinical context. Changed for the better, of course. So which beliefs should we focus on? Well, colleagues of mine within health psychology, Howard Leventhal and colleagues in particular, have focused on a cluster of 5 particular beliefs that tend to predict most clinical outcomes. And so using this framework will be a helpful way forward. And so focusing on whether how patients think about the experiences they have, the symptoms they have, how they label those symptoms, can make a difference, can shape their thinking about whether there is a cure for this condition, the degree to which patients think that they can control this condition, the consequences of living with psoriasis in this case, and the timeline, whether they feel that this timeline, whether they think that this timeline is likely to, this condition is likely to get worse over time, to get better over time, to stay the same, a rapid decline or a rapid improvement. All of those features of the timeline can predict whether people take their medication and continue with their medication. If, for example, somebody has an acute timeline that they think, oh, well, this condition will clear up fairly quickly, and they start taking their medication, but it doesn't actually improve for some time, then this will discourage patients from continuing with the medication. So giving the patients a clear understanding of what they can expect from a medication or a management feature within a certain time frame will be helpful. So using this framework of these 5 core beliefs that can predict outcome will be helpful for you as clinicians and for patients to work with. So these are some examples. I'm not going to go through each of these, but just to pick out a few features of the beliefs that may be helpful. So, for example, if patients perceive psoriasis as a threat to their health, which of course we know it is, but also a threat to their identity as a person, as a family member, as a father, as an employee, this will impact on how they think about these 5 core beliefs and predict their emotional reactions to it. For example, if they believe that if they have an unrealistic cause of their psoriasis, then this will prevent any necessary behaviour change. If they're continuing to smoke when they have psoriasis, or if they're very overweight when they have psoriasis, but they don't feature the factor of being overweight or smoking within their psoriasis management, then there's no incentive for them to try and change that behaviour. Similarly, we can then predict from their cluster of beliefs, and of course we know these beliefs from asking people in a clinical context about those 5 core beliefs. We can then predict how they might feel, whether they feel anxious, stressed, fearful of the future, and or whether they have low mood and depression. So one of the ways in which we can try and attempt to predict how people might feel is if they're reporting numerous symptoms that are not necessarily related to psoriasis, but the patient thinks that they might be related to psoriasis. This symptom over-reporting is often a predictor and a feature of anxiety, health anxiety in particular. It gives us an insight to how people might be thinking. So when we're working as a clinician in the context with patients, you need to focus down and to selectively attend to some of these beliefs and asking the patient which are the most bothersome to you in the clinical context will give you some insight to how patients think. Which are the most bothersome symptoms? Asking the patients whether they have a willingness to self-manage. To what extent do you feel, you might say to the patient, do you feel that you can help to control your condition? And focusing on their expectations of treatment outcomes. When would you expect this treatment to work? Over what period of time would you expect this treatment to work? All of these will give you an insight into that cluster of 5 core beliefs. But in addition to that, we know that patients have beliefs about medicines that can be helpful or less helpful. And again, we find that there is a consistent non-adherence problem within psoriasis. Up to 40% of patients with psoriasis don't take their medicines as prescribed. And Professor Augustine has done some more recent work than that, showing that the estimates for non-adherence range vastly from 27% up to 90%. The reason for this huge variability within non-adherence is not everyone uses the same measure when they are attempting to assess non-adherence. So we need some standardized measures of adherence within psoriasis. But in particular, I wanted you to focus on 2 kinds of beliefs about medicines. One is, how necessary is this medicine, and what concerns do you as a patient have about the medication? If you ask the patients those 2 questions about the necessity and about the concerns, this will give you an insight and help you to predict whether they're likely to adhere to the medication or not. And in particular, where we have the concerns about the medication outweighing the necessity, then you have a problem. Patients are likely to stop taking the medication. Some patients are quite suspicious about clinician behaviour in terms of overprescribing. Often what they'll say to me as a psychologist in a consultation is, oh, well, you know, doctors are always overcautious. They tend to prescribe when they don't need to. So I'm not sure about this medication, whether it's the right medication for me. Many patients are concerned about unnatural substances. They will often say things like, well, medicines are not natural, and so I would prefer to try and use some natural substances in order to manage my psoriasis. And if you probe that a bit more carefully and a bit more clearly, you find that most patients have a very shaky understanding of not only what medicines are, but how they work. And so your job as a clinician is to help them to understand that more effectively. I drew your attention to the fact that we can understand patient behaviour in terms of adherence, and there are 2 ways in which we can do that. There's the beliefs about medicines questionnaire, which is quite a simple measure that helps us to understand that balance between necessity and concerns. And I would strongly advise you to have a look at the work of a colleague of mine, Rob Horn, who's done much of the work in this area. Rob is a pharmacist, and he's doing quite a lot of work in non-adherence from a health psychology perspective. So I'm not going to go through this slide in any detail either, other than just to say that beliefs about the medicines in particular will drive particular non-adherent type behaviours. For example, many patients think this topical treatment, this emollient, will make my skin very unattractive, it'll look very greasy, it'll rub off on my clothes and so on. And of course, you know, the outcome of that is patients are likely to stop using their medication. I did mention earlier also that clinicians' personal models, the way that they think about patients, about medicines and about treatments, also predict clinician behaviours. And some of the early work that we did with Professor Griffiths in Manchester on the Impact programme showed that this cluster of beliefs that clinicians have can predict how they behave in a clinical consultation with patients and can help to shape clinician beliefs. And some more recent work that we've done looking at, with a new treatment, how clinicians think about that new treatment and how they convey that to patients can predict patient outcomes, particularly in relation to non-adherence. And this is a relatively new area for research within psychology, and I would hope to see more exploration of whether it actually does predict patient behaviour in terms of non-adherence and self-management later down the line. So we know also that now these cluster of beliefs can impact on mood. We know, for example, that decreased quality of life within psoriasis is substantial and is comparable with the decreased quality of life that we see with other long-term conditions, including chronic obstructive airways disease, cancer, cardiovascular disease, and so on. Significant proportions of your patients will be experiencing anxiety, social anxiety, and health anxiety. Around a third of your patients, and many of them will be experiencing low mood and depression. And of course, unfortunately, we know a significant proportion of those people with low mood will be contemplating ending their own lives. How many of those people go on to take their lives? We don't really know. But we also know that clinicians are not very good within the consultation of picking up those people who are likely to be depressed for a range of reasons, not least of all because patients will hide, will mask their low mood and depression. And so within a rather hurried consultation, they're not likely to communicate to you that they're feeling suicidal. So your job as a clinician, even though it's a difficult area to work in, is to ask patients how they feel, whether they think their life is worth living, and if they say no, to measure that in a reliable way, and of course to enlist the help of your colleagues within mental health. We also know that there is very poor service for patients who are depressed with living with psoriasis, and the all-party parliamentary group on skin in the UK, in England specifically, have identified that dermatology services for patients in general are not only poor, but they've got worse over the last 10 years and not improved at all. So the likelihood of you having people that you can work with easily within dermatology to help you manage your psoriasis patients is very slim. And for you as clinicians, that's a task for you to work with and to improve service provision for those patients. I've already mentioned that many of your patients are socially anxious. That's the focus of their anxiety. Quite often they're very worried about what people think of them, what people interpret when they see their skin, and whether they're going to be rejected. Many of your patients are very fearful for the future. They now know that there are comorbidities associated with psoriasis, and they're very fearful of those comorbidities in addition to the health impact of living with psoriasis alone. Patients outside of a free healthcare system are very worried about the economic insecurity. Treatments are expensive, and many of your patients are very well aware of that. And particularly in the UK, we're experiencing many patients are experiencing financial difficulties, even within a free healthcare system, where they're having to consider whether they can afford all of the treatments that they need to manage their psoriasis. But we mustn't forget that most patients living with psoriasis do manage effectively. They self-manage, they cope with living with anxiety, they cope with all aspects of working with psoriasis, but many don't. And it's this group of people that we need to dedicate additional attention and resources towards. What's important? We know that if patients are anxious, they're not going to be self-managing effectively. We talk about that as poor self-regulation within psychology. We talk about low self-efficacy, a sense that you as an individual can't do very much in order to manage your condition. And this leads to worse self-management more generally. And it's very likely to lead to lower levels of adherence. Why this is particularly important is because it has behaviour outcomes in terms of patients, if they're anxious or if they have low mood, will self-medicate in order to try and manage that mood. They will often be using alcohol, or they may be using other drugs as a way of managing mood. And of course, all of those may interfere with good psoriasis management. Many of them will limit their social contact, leading to further low mood and an ever decreasing downward spiral of non-coping. And one area that hasn't been fully explored within psoriasis is increased sympathetic nervous system activity associated with both anxiety and low mood and depression. We know that this is implicated in other long-term conditions, particularly cardiovascular disease, where it has a cardiotoxic effect, but we don't know very much about the impact of increased sympathetic nervous system activity on inflammatory processes. But of course, we do know that anxiety changes the gut microbiome, for example. So this area of psychophysiology really needs to be explored more thoroughly and in a more effective way. So low mood and depression inhibits optimal self-management, but depression, full depression, prevents optimal self-management. So we need to take it seriously, and it becomes this self-perpetuating cycle. So what we have to do, all of us as clinicians, whether you're working as a dermatologist or as a health psychologist like me, we need to switch patients' thinking away from health-threatening features to health-protective features within the conversation. And so we need to help people to understand, as many of you are doing very effectively, how their being heavy, being overweight, their weight gain, how that impacts on their psoriasis. We need to show them and encourage them to understand how smoking, excess alcohol use, other substance use, all of these features, how they impact on their psoriasis, how medication misuse, particularly non-adherence, has a direct effect on their psoriasis management, and how understanding how their chaotic management, disunited, unhelpful, contradictory behaviours, how this is not a feature of their character as people, but it's a feature of their anxiety, it's a feature of their poor understanding, rather than blaming or labelling patient behaviour as unhelpful, trying to dig underneath the behaviour and understand it and predict it from these health beliefs, from these medicines beliefs, and from low mood and anxiety. And so one of the ways in which we can do that is to measure it effectively, because many of the measures which you will be unfamiliar with and will help you to get a better understanding of the theoretical models and the information that lies behind measuring those factors. So I've mentioned the brief illness, I mentioned the beliefs about medicines. I haven't mentioned the belief illness perception questionnaire, the brief illness perception questionnaire, the BIPQ. It's a very simple 10-item measure of these core beliefs, this cluster of 5 core beliefs. And it's something that the patient can complete while they're waiting to come to see you in the waiting room or while they're at home. And this can form the basis of a discussion within the consultation. If you're concerned about patient mood, of course you can use the patient health questionnaire, the 2 items and then the 7 items if you think that the patients are actually anxious or low mood. And if you have established that there's a positive response to the PHQ-7, you can go on to measure through the Hospital Anxiety Depression Scale anxiety and depression in more detail. Both scales, the anxiety scale, have 7 items, and the depression scale has 7 items as well. Simple measures, but can give you a much clearer picture and help you to quantify the degree to which patients might be low in mood or anxious. You will be more familiar with the DLQI than I am, and we will hopefully have another impact measure coming on stream fairly soon. But once you have a clear understanding of the beliefs that make up the low mood or the anxiety, then featuring on a goal to change behaviour with something as simple as the goal attainment scale, which I haven't got time to go into now, but I'd be very happy to talk to you about if you wish to discuss it in the future, can form the focus of the consultation for you. So I'm going to skim through these because I'm very well aware that I've run out of time. This is the brief illness perception questionnaire. This is the PHQ-2, 2 items. And this is the hospital anxiety and depression scale. And you will see how it's configured and how it's measured on these slides. So then using this information will help you to monitor the current care that you give patients, and will help you to escalate care if necessary, to move patients onto other medication, and to guide in the consultation towards behaviour change and better self-management for patients, but will also form the basis of a clear and focused referral to specialists if you believe the patients need better quality mental health input to their management. So the key messages from today are: complex psoriasis should be assessed in the round, and this includes psychological functioning. And I appreciate it's not easy for you as clinicians to be able to do all of the things that you have to do within the consultation. So please enlist your colleagues from mental health. Measuring quality of life alone doesn't give you a clear steer for intervention. It simply gives you a descriptive snapshot of the impact that psoriasis might be having on a patient's life, but it doesn't give you a steer for how to help the patient to manage that more effectively. Illness beliefs, treatment beliefs, and emotional reactions are more predictive of non-adherence than other health risk behaviours. And whole person management is the next step in excellent patient care. So thank you very much for your attention.